Welcome to the Nursing World NCLEX Content Review class. This class is a package for your success and comes with daily assessment using our NCLEX question bank. You get 5 contact lectures weekly with an option of either a live or recorded video class. You're also provided with assistance and guide on how to register for the NCLEX yourself. And you also get an assigned instructor for follow-up and guidance until the day of your exams. So today we'll be looking at health promotion and maintenance, specifically labor and delivery. Let's start with assessment. Remember, in labor and delivery, you must start with your assessment. What are you looking out for? Characteristics findings. You're looking out at onset of labor, cervical changes, you're looking out for ruptures of membranes, and in onset, you must assess for lightening, which is that subjective sensation as a fetus descends into the pelvic inlet. Remember, in primates, this could occur up to 2 weeks prior to delivery, whereas in multiparas, it may not occur until labor begins. You're also looking out for softening of the cervix. You're looking out for expulsion of mucus plug, which is also called show. And again, you're assessing for uterine contractions that are progressive and regular. So if you look at this, you'll see in this, the cervix is not effaced or dilated. And here, the cervix is 50% effaced and still not dilated. And here, the cervix is 100% effaced and dilated to about 3 cm. Whereas in this last picture, the cervix is fully dilated to 10 cm. Okay, so in cervical changes, which was the second point, you're looking out for effacement. When we talk about effacements, we refer to the progressive thinning and shortening of the cervix, where you look at it from 0 to 100%. Then we talk about dilatation, we're referring to opening of the cervical os during labor, which is measured in centimeters when we talk about 0 to 10 centimeters. Well, we look at the third point, which is the ruptures of membrane. You're looking at if the amniotic sac has ruptured. And again, when this happens, you want to check fetal heart tones to assess for fetal distress. You also want to assess for prolapsed cord. And symptoms you would notice is prolapsed cord would occur when there's premature ruptures of membrane, when the presenting part is not fully engaged. If there's fetal distress, you want to suspect prolapsed cord. And then if you can physically see the protruding cord. And your nursing care at this point will include, you need to call for help. Again, you want to push against the presenting part to relieve pressure on the cord. You also want to place the patient in Trendelenburg or a knee chest position. And if this treatment is successful, the fetal heart rate will remain unchanged. Let's go to fetal monitoring. One way to monitor the fetus, you can carry out intermittent auscultation, or you can carry out electronic monitoring, which could be external or internal. In external electronic monitoring, you could have your ultrasound over the fetal back, which monitors the fetal heart rate. And then you can have an external pressure transducer monitor, which also monitors uterine tone. It's transabdominal, it's non-invasive, and the client needs to decrease extra-abdominal movement so that it doesn't alter your readings. Whereas in internal monitoring, you have a fetal scalp probe, which provides the fetal heart rate. So this would be our fetal scalp probe, which monitors, gives us information on the fetal heart rate. And then there's an internal transducer, which provides intrauterine pressure reading. So this will be our internal transducer. Remember, membranes must be ruptured, cervix sufficiently dilated, and the presenting parts must be low. It's an invasive procedure. And normally, your results of monitoring, the normal rate should be between 120 to 160. So you must obtain a baseline data as you progressively monitor your patients. Okay, you could also have the fetal heart rate being fast, which will be referred to as tachycardic, or being slow, which we refer to as bradycardic. And remember, tachycardia is an early sign of fetal hypoxia. Please note that down. Tachycardia is an early sign of fetal hypoxia. When you see bradycardia, that's a very, very late sign of fetal hypoxia. You need to intervene. Okay, so tachycardia, we said it's an early sign of fetal hypoxia. Usually, these are readings greater than 160 beats per minute, lasting longer than 10 minutes. It's usually associated with maternal fever, fetal anemia, fetal or maternal infection, use of drugs. It's also seen in maternal hyperthyroidism, fetal heart failure, and it's a non-reassuring sign when associated with late decelerations, severe variable decelerations, or absence of variability. Don't worry, we'll look at all of these terms in subsequent slides. Bradycardia, which we said is a late sign of fetal hypoxia, is usually less than 110 beats per minute, lasting longer than 10 minutes. It's associated with maternal drugs like anesthetics, prolonged cord compression, fetal congenital heart block, maternal supine hypotensive syndrome. And again, it's a non-reassuring sign when associated with loss of variability and late decelerations. So we've talked so much about variability, decelerations. Let's look at what variability is. So variability is the beat-to-beat fluctuations, which you would normally see, usually measured when you use your electronic fetal measuring or monitoring. So you would usually see that beat-to-beat fluctuations. It's usually normal if it's between 6 to 25 beats per minute, and it's an indicator. It tells you the fetal is doing well. So you want to see your readings at between 6 and 25 beats per minute. When it's absent, usually between a range of 0 to 2 beats per minute, or decreased in the range of 3 to 5 beats per minute, it may be associated with fetal sleep states or fetal prematurity, or maybe the fetus is reacting to drugs such as narcotics, barbiturates, tranquilizers, or anesthetics. It could also be associated with congenital anomalies, hypoxia, acidosis. If it persists for more than 30 minutes, this may indicate fetal distress. An absent or decreased variability may indicate fetal distress if it has persisted for more than 30 minutes. But again, the significance is not known when it's increased above 25 beats per minute. Okay, so this is a graph of different variability readings. A, B, C, and D are different variability readings. And the last one, which is E, is uterine contractions. So let's look at what each of these mean. Let's start with the first one, accelerations. Normally, it should be 15 beats per minute rise above the baseline, followed by a return to the baseline. So you could see this rise and then back to the baseline. Okay, if it's within 15 beats per minute, and it's usually, you see this in response to fetal movement or contractions, it actually indicates fetal well-being. Now, decelerations is usually a fall below the baseline, lasting 15 seconds or more, followed by a return to the baseline. So if you see a fall below the baseline and it lasts more than 15 seconds, then that is a deceleration. We could have early deceleration. It could be late deceleration. It could be a variable deceleration. So this early, late, variable. In early deceleration, the onset is close to the beginning or before the peak of contraction. So we are looking at early deceleration and we are comparing it to our contraction graph below. So you can see it's actually, the deceleration starts close to the beginning or before the peak of this contraction. So this is your contraction peaking and going back to the baseline. This is our deceleration dropping just close to the beginning or before the peak of the contraction. most often uniform mirror image of contraction. So you can see this is going up and this is going down. They are both like a mirror image of each other. Usually it's associated with head compression, in second stage with pushing, but again, it's also a reassuring pattern. In late deceleration, which with this D, the onset after contraction is established, usually begins at the peak of the contraction with slow return to the baseline. So you can see this is the peak of the contraction, and that is when your deceleration starts to occur. So contraction is usually established before you start seeing that deceleration. And then it takes it very, very slowly before it returns back to the baseline after the contraction has completed. So this will be your late deceleration, and it's indicative of fetal hypoxia because of deficient placental perfusion, which could be caused by factors such as pregnancy-induced hypertension, maternal diabetes, placenta previa, abruptio placenta. Again, this is a non-reassuring sign. And then we look at variable deceleration. Variable deceleration. This is a transient, it's either U or most times it's V-shaped reduction occurring at any time during uterine contracting phase. It occurs at any time. It doesn't mirror the uterine contraction, or it doesn't start before a particular contraction. It could occur at any time during uterine contracting phase, and decrease is usually more than 15 beats per minute, and it lasting up to 15 seconds. And then there's a return to baseline in less than 2 minutes from onset. It's indicative of cord compression, which may be relieved by change in the mother's position. But again, it's a very bad sign. It's ominous if repetitive, if it's prolonged, if it's severe, or there's slow return to baseline. Please, at this point, you want to administer oxygen. If the client is on oxytocin, you want to immediately discontinue oxytocin. So remember, variable decelerations, U or V wave, they can occur at any time during the uterine contraction. It's usually more than 15 beats per minute. It lasts close to 15 seconds, and it takes a very slow return, up to 2 minutes, in less than 2 minutes from onset. So that is your variable deceleration. So what are your nursing interventions for abnormal results from your fetal monitoring? Well, for early decelerations, you don't need to do much. There's not much you can do. For late decelerations, at the first sign of abnormal tracing, you want to position the mother left side lying. If no change, move to other side. Again, you want to put her on Trendelenburg box or knee chest position. Administer oxygen by max. Start an IV or increase the flow rate if she already has an IV line in situ. Stop oxytocin if appropriate, and prepare for C-sections. For late decelerations, these are actions you must take. For variable decelerations, reposition the mother to relieve pressure on the umbilical cord. Let's look at factors affecting labor and delivery. One major factor you want to consider that could affect labor and delivery is the fetal lie. Remember, the fetal lie is the relationship of the spine of the fetus. So this is the spine of the fetus to the spine of the mother. Okay? So this would be your normal longitudinal lie, which is parallel. This would be your transverse lie, which is right angles. So the fetal spine is at right angles to the mother spine. And again, it could be oblique, which is a slight angle off a true transverse lie. Okay, so these are what you need to consider. You want to consider the lie because this could affect labor and also affect delivery. Okay, you want to also look at presentation. So when we talk about presentation, we're looking at the part of the fetus that presents to or enters the maternal pelvic inlet. So which part of the fetus enters into the maternal pelvic inlet? It could be cephalic or vertex, which would be the head is the presenting part, and this occurs in 95% of labor. It could be breech or buttocks, which is this, which occurs in 3 to 4%, or again, it could be a transverse lie or a shoulder lie, which is usually rare. Remember, in breech presentations, you could have a frank breech, which is a flexion of the hips and extension of the knees. It could be a complete breech, which is a flexion of the hips and knees. It could be a footing or incomplete, where you have extension of the hips and knees. Okay, again, you also want to consider the attitude, which is the relationship of the fetal parts to each other. Usually, there should be flexion of the head and extremities on the chest and abdomen to accommodate the shape of the uterine cavity. So you want to monitor the fetal attitude. Another point you want to monitor that could affect your labor and delivery is the position. This is also a relationship of fetal reference point to maternal pelvis. Okay, so you can see the maternal pelvis is designated as this is the patient's right and this is her left. Again, this is posterior, which is to the back of the pelvis, and then anterior, which is to the front. So to find the best locations for fetal heart rate assessment, you first of all want to determine the location of the fetal back. And then if you look at our fetal reference points, it could be vertex presentation, which is dependent upon degree of flexion of fetal head on chest. It could be full flexion, where it will be representing the reference point will be the occiput. It could be full extension, which would be the chin. It could be moderate extension, which would be the bra. Okay, and then there's also breech presentation, and then there's a shoulder presentation. And remember, these are expressed as standard 3-letter abbreviations. Example, you can see the LOA, which is the left occipital anterior or left occiput anterior, which is indicating vertex presentation with fetal occiput on the left side towards the front of the pelvis. To find best location for fetal heart rate, like we said, determine the fetal location or determine the location of the fetal back. Remember, weeks of gestation may alter the location as well. So this would be your LOA, left occiput anterior, and fetal heart rate best heard below the umbilicus on mother's left side. If you consider how the fetus is lying, this would be your right occiput anterior. There's also your right occiput posterior, and then there's also your right occiput anterior. So these are all different positionings with reference to the fetal reference points. Another factor that may affect labor and delivery, you want to consider the configuration and diameter of the maternal pelvis. You also want to consider the distensibility of the uterus. How distensible is the maternal uterus? And again, you're looking at the station. Remember, your station is the level of presenting part of fetus in relation to the imaginary line between the ischial spines. So this would be your station. It's the 0 station in male pelvis of the mother. So this is at 0. -1 to 5, which would be above the 0 station, indicates a presenting part above the 0 station. Here you can say is in the floating phase. And then +1 to +5, you have the presenting part below the 0 station. An engagement is when the presenting part is at station 0 or below. Remember when we talked about engagement? So in reference to station, it should be below 0. It should be at station 0 or below. Again, we also need to consider contractions. What are the characteristics of contractions? Remember, there are 3 phases. There's the increment phase, which is this point, where you have this steep crescent slope from beginning of contractions until its peak. And that peak is also called the acme, which is a point of the strongest intensity. And then there's a decrement where you have diminishing intensity, and then there's a resting stage. Okay, so what are the characteristics of contractions? You want to consider the frequency of your contraction. Remember, frequency is a time frame in minutes from the beginning of one contraction to the beginning of the next one, or the peak of one contraction to the peak of the next contraction. Remember, frequency less than every 2 minutes should be reported. Frequency less than every 2 minutes should be reported. Another characteristic of contraction is the duration. Duration is a time frame in seconds from the beginning of a contraction to its completion. So this is our duration from the beginning of a contraction to its completion. Don't confuse that with frequency, which is time in minutes from beginning of one contraction to the beginning of the next contraction. Remember, more than 90 seconds duration of any contraction should be reported because of potential risks of uterine rupture or fetal distress. Again, we need to consider intensity. So this would be our intensity. And this is the strength of a contraction at acme or at the highest point. It may be assessed by subjective description from the mother. It could be assessed by palpitation, where we could say it's mild contraction. If the slightly tense uterus can be indented with your fingertips, then we say it's still mild contraction. We can say it's moderate if you have a firm fundus, difficult to indent with your fingertips. Then you could refer to it as a strong contraction where you have a rigid board-like fundus. Again, you must be able to differentiate true from false labor. Remember, we have in true labor, the cervix is progressively effaced and dilated, but you don't see cervical changes in false labor. In contractions, in true labor is regular with increasing frequency. The intervals begin to shorten. Okay, the duration, the intensity, they all have this, they keep increasing. But in false labor, contractions are irregular with usually no change. There are no change in frequency, duration, or intensity. Again, in true labor, the discomfort radiates from the back around the abdomen. But in false labor, the discomfort is usually abdominal. Again, in true labor, contractions do not decrease with rest. But again, in false labor, contractions may lessen with activity or rest. So let's consider some cultural influences that could affect labor and delivery. And you should note some of this. For the Japanese, they usually prefer natural childbirth, and they may labor silently. They may be progressing. So you don't want to get confused with someone who is calm, a Japanese who is calm and not shouting and screaming in labor. Remember, not all members of a culture will choose these actions. In China, you have this stoic response to pain, and they prefer sideline position for labor and birth. That's usually seen in the Chinese. In India, they would want to request female relatives be present. And in Laos, may prefer using the squatting position for birth. Just to mention some potential nursing diagnoses for labor and delivery. Remember, there's a potential for knowledge deficits. There's difficulty adapting and coping with stress. There's a possible risk of complications. There's a need for pain management, and labor may not progress. So these are your potential nursing diagnoses. Okay, so let's look at monitoring. We talked about monitoring the fetus. Let's look at monitoring the mother. Okay, in the first stage of labor, which is the beginning of labor, to complete cervical dilatation. Phase 1, we have the latent phase, which is between 0 to 3 cm. Contractions are usually 10 to 30 seconds long and 5 to 30 minutes apart. and it's usually mild to moderate. In phase 2 of the first stage of labor, the mother can progress to the active phase, which is between 4 and 7 cm. Contractions now become more intense, between 40 to 60 seconds long, and they are now shorter, happening within 3 to 5 minutes apart, and it's usually moderate to strong. And in phase 3, which is the transition phase, the cervix is between 8 to 10 cm. Contractions get more intense, between 45 to 90 seconds long. Remember, we said any above 90 seconds, you want to report it. And again, they are now 1.5 to 2 meters apart. And they are usually very strong. The second stage, which is by then we should have had complete cervical dilatation to delivery of the fetus. In phase 1, the child or the fetus is between 0 to +2 stations. Contractions are usually 2 to 3 minutes apart. In phase 2, the fetal presenting part is between 2 +2 to +4 station. Contractions are between 2 to 2.5 minutes apart. There's increase in dark red bloody show. There's also an increased urgency to want to bear down. And in phase 3, which is between +4 to birth, contractions are 1 to 2 minutes apart. The fetal head is visible. There's very much increased urgency to bear down. Remember, in the third stage of labor, birth and delivery of placenta is what occurs. In placenta delivery, you're looking out for a slight gush of blood and lengthening of umbilical cord. Again, you also want to check for remaining fragments that could have been retained. In the fourth stage of labor, which is the first 4 hours after delivery, you want to keep monitoring your client. In terms of fetal progress, you want to monitor the fetus. During labor, you want to check fetal heart rate. Again, you want to manage fetal distress. If you notice irregular fetal heartbeat, you want to turn the client onto the left side, give oxygen like we discussed earlier, check for prolapse cord, start an IV line. If there's an umbilical cord prolapse, you want to elevate the presenting part to relieve pressure of the cord. You want to call for help, place client in Trendelenburg box or knee chest position, give supplemental oxygen, and start IV line. Again, monitor for discomfort, exhaustion, pain control, and you want to support the client in her choice of pain control. Relaxation techniques taught during pregnancy, where breathing is taught as a relaxed response to contraction, should be encouraged. Low back pain, you can advise massage of the sacral area, use different breathing techniques during different phases of labor, and encourage rest between contractions. Again, you want to keep the couple informed of progress. Administer analgesics. Consider the orders you have for analgesics, the client's request. You also want to consider the stage of labor and fetal well-being in your choice before you choose the analgesics you want to use. Remember, these analgesics may prolong labor and all of that. Some of the analgesics we could talk about are anesthetics. When the mother wants to make a choice, you want to educate the client about anesthetics. We have the systemic analgesics. We also have the nerve block analgesia and anesthesia. For the systemic analgesics, they are the opioid agonists and the opioid agonist antagonists. For the opioid agonists, morphine is one of them. Always remember, with the use of morphine, there's a risk of maternal and fetal respiratory depression and sedation. For opioid agonist antagonist analgesics, you have butorphanol, it's now buphine. There's also less risk of respiratory depression. So this is usually more preferred because of its less risk of respiratory depression. For your nerve block analgesia and anesthesia. It could be the local analgesia for episiotomy. You can use lidocaine, chloroprocaine. They may be given with epinephrine. And then for the pudendal nerve block, it could also be used for episiotomy or when forceps or vacuum extractor is used. For spinal anesthesia, you also want to educate the client. It's used for cesarean birth, local anesthetic with fentanyl injected into the subarachnoid space at the level of the 3rd to 5th lumbar vertebra. Okay, so this would be your spinal anesthesia between the L3 and L5. There's also risks of maternal hypotension and respiratory depression. You need to educate the client about this. There's also risks of fetal distress, and post-dural puncture headache is usually common. Again, there's also the epidural anesthesia or analgesia block. In epidural, it could be lumbar, which is injected into the epidural space between the 4th and 5th lumbar vertebrae. Examples are the bupivacaine, ropivacaine, fentanyl, sufentanil. They may be client-controlled epidural analgesia. Again, you also have the combined spinal epidural analgesia, and this is opioid injected into the epidural space, followed by local anesthetic. Newborn care. Prepare for delivery. It could be normal spontaneous. It could be vaginal birth after cesarean. So your newborn care delivery are the immediate actions you carry out. You want to establish an airway, observe for Apgar score at 1 and 5 minutes, clamp umbilical cord, always remember to maintain warmth, and place identification band on baby and mother. And as part of your evaluation, you want to evaluate if the mother can participate effectively in delivery process. Is mother able to rest between contractions? Has mother established eye contact with neonate after birth? Have complications with mother being affected? And this is the end of the course.